Hi, I'm Lucy Davis.
And I'm Hasan Tahir.
And this is Room for Improvement, the podcast dedicated to service improvement in axial spa care. So on today's episode, we're really delighted to have one of our Aspiring to Excellence team members coming to talk to us about their project and some of the work that they've done and the real pivotal role stakeholder engagement can play in successful improvement for our services, and how sometimes some of those changes that can happen outside of the control of a clinical team and the impact that can have, and how we can use engagement and the power of improvement tools to really bring out the best possible outcome for our service.
So Lucy, I love the title of our episode. It's called Teamwork Makes the Dream Work, Collaborating Across Multiple Disciplines. That sounds quite exciting. And I'm delighted to welcome Dr Ben Thompson, who's one of our rheumatologists from Newcastle upon Tyne, NHS Foundation Trust. Hi, Ben.
Hello, Hasan. Hello, Lucy. I'm delighted to be included. Thank you very much for the invitation.
Brilliant, Ben. Ben, I understand you're the lead for the Axial SPA service at your trust. Would you mind just starting off and telling us a bit about your Axial SPA service prior to you actually engaging with the Aspiring to Excellence program? Yeah,
sure. So we have quite a big service in Newcastle. There were 4 consultants. Now we had quite a strong physiotherapy input as well, with an extended scope physio, more in motion, who kind of supervise a team of physios who would be involved in kind of the care. So patients could self-refer to physio if they were flaring, and they would also be seen multiple times soon after diagnosis for sort of education around axial spa and around the exercises they should be doing. So that was certainly a key part of our service in Newcastle.
So basically, you're saying that prior to the Aspiring to Excellence, your service was integrated with physiotherapy, and a lot of patients would come through physiotherapy with Axial SPA.
Yeah, absolutely. I mean, it was nice to know the physios that would see our patients and to know that they were getting sort of high quality care when they did that, alongside all the medical care and occupational therapy as well, and other sort of multidisciplinary team with specialist nurses. So I guess that was the key sort of part of our service, was the physios, and that was what was disrupted. And in the end, we kind of tried to address and improve.
Okay, so that was your service. So you were, I think, the first batch who were very fortunate, very successful in actually being part of the Aspiring to Excellence. So what did you deem to be the most important issue that you wanted to deal with to improve?
So I guess it's important to say there was a sort of a service change in terms of physiotherapy in the Newcastle Gateshead area, and this was a kind of a bringing together of community and hospital physiotherapy services. And this had an impact on us, on our care for patients with axial spondyloarthritis. So this was a new organisation that formed called TIMS, which was the Tyne Side Integrated Musculoskeletal Services, which sort of combined the hospital and community services. It was a first point of contact for people with musculoskeletal problems in the community, and was the only way into orthopedic services. So this new organisation actually took on a lot of the physios that we had within rheumatology. So we no longer had a rheumatology physio team. And I think actually this kind of made us think, well, actually, are we still able to identify people with AXPAR? So people could self-refer to TIMS, which was fantastic. But actually, we had less kind of input and understanding about what went on in this organisation in terms of, were they recognising those patients with inflammatory back pain that needed to be referred to us? And then secondly, a second problem that we kind of addressed through Aspiring to Excellence was what happened to those patients who were newly diagnosed with axial spondyloarthritis. Were they still going to get the same high quality physio care and education that we were able to offer before?
So what you're saying is that basically there was a concern about oversight before you had actually oversight of what your physios were doing. You knew, appropriately they were seeing, appropriate diagnoses were made. But the concerns were that now you'd gone out into intermediate care or community care, that you may not have that oversight and therefore miss appropriate patients. I mean, is my understanding correct?
Yeah, absolutely. So it was kind of disrupting that kind of pathway potentially of new diagnosis, and also the pathway for newly diagnosed by us who require this kind of really essential input in terms of these are the exercises you should be doing regularly to prevent loss of movement in your spine. And this is the way back into the service if you're flaring. So yeah, absolutely oversight and a little bit of kind of training, and also knowing that they could come to us if they had problems as well.
I think what's really interesting is this is exactly that part of when we talk in the Aspiring to Excellence program, we talk about Deming's system of profound knowledge. And one of those things is about understanding our system. And here in this particular project, we had an instance of a change being made at a service level, and then the consequence of that not quite being fully understood, or the consequences of that within the Axial SPA service. And so it seems like it really was ripe for that quality improvement, because when you guys came to the program, it was really thinking about understanding the system and then thinking about those key stakeholders within that. So I wonder if you want to tell us a little bit more about how you started to go about that and how you went through that process.
So I think the first project we looked at was around kind of the routine. So the diagnosis section of are people who are referred by their GP to the musculoskeletal service, or who self-refer, are they be identified as having inflammatory back pain and referred on to rheumatology appropriately. So we kind of set up, this is these are the referral criteria that we want, using the expert criteria for inflammatory back pain. And these are the patients we want. And we kind of audited before and after and said, actually, with some education and with saying this is a priority, we were able to show that the physios who were doing this, the assessments were referring appropriately, were using our criteria. And we were actually pretty confident that we were finding those patients, that we weren't missing them.
So Ben, how can I ask for our listeners, how did you go about engaging with the physio or your intermediate care? How did you go about undertaking this education program?
Yeah, so I think this first project actually worked quite well without a lot of kind of toing and froing, and actually went reasonably smoothly. The later stage required quite a lot more kind of discussion about how it would do. I think, first of all, it's trying to work out who those important people are. Who are your important stakeholders? So actually, it was about, within our hospital trust, we're in a musculoskeletal directorate, so there are managers there that are that need to kind of realise this is a priority. Also, there's the TIMS management as well, and also the kind of the physios actually on the ground, which was interesting to be able to try and engage more effectively with those. So it's really trying to work out who the important people are, bringing them together. So actually, setting up a working group was met regularly that we could discuss these problems with. Really trying to improve that kind of communication between the two organisations, which was actually a priority for lots of people at the time, because it wasn't just us that were struggling to make it work effectively.
Absolutely. And I suppose I'm interested there, Ben, with some of that work where you kind of have good conversations and start to that engagement process. Were there any tools that you used in particular that were useful in that engagement process? So as I'm conscious, I can speak entirely for myself. I don't like people telling me where I need to improve. I like to be able to work through that together with somebody. So is there any way you kind of got around some of that potential challenge that may have been there?
So I think it was really kind of understanding what everyone's kind of priorities were and what they were trying to do, and how we could help. I guess, trying to be available for clinical advice and being the helpful person that is, that can offer solutions to problems to the physios on the ground, trying to kind of bring them together. And we formed a multidisciplinary meeting and invited those physios to attend as well. So I guess you can map out who the stakeholders are and what their level of influence are. You can identify them in those ways. You can really it's about trying to share what you're trying to do, trying to focus on patients and say, this is the way that we can improve patient care. This is the way that we can make things better for you. So those were the sort of, I guess, hooks that we had.
What I find interesting, I mean, the challenges that we face, certainly where I am, is, when you go to primary care or intermediate care, actually finding out who those individual stakeholders are. I mean, was that a challenge at your end? I mean, you've got this big organization, TIMS. I mean, who is the person? I mean, did you find that a challenge?
Yes, that was good. So we invited the TIMS lead to come and speak to us as a department to say, tell us how it's working. What are your priorities? So that was interesting. And then you have someone who's the lead for pathways. But then actually there was also sort of, a need really to find out, because there's a tendency, I think, for some managers to sort of say, everything's fine, we're doing everything great. And then you get this sort of second line in of, actually, if you speak to the physios, they're having particular problems dealing with these patients. They're perhaps not as confident as what they would be. And so there's two ways into the organisation, I think. So, yeah, no, absolutely. It's a challenge to try and find out how an organisation like that works. Yeah.
I mean, what I found, and I'm not sure whether you find that was a challenge as well, is that, as you mentioned the word priority, so their bosses may have a different priority, and obviously you have a different priority. I mean, was that an issue? I mean, at your end?
Yeah. So our priority is looking after people with axial SpA, and I'm quite open with that and saying, these are really important patients because this is such a key part of their kind of care and their management. And if we don't get this right, they're going to come back more often. We're going to have to see them more often. And ultimately, they're not going to do as well. They're going to poorer quality of life. So, with a smile, you say, this is what I'm going to talk about. But actually, you appreciate, that one of their issues is that orthopedic surgeons will be shouting at them about their post-operative patients. And there's a huge waiting list of patients who are self-referring to them. And so you kind of understand that. And you're saying, yeah, this is what we're focusing on. Being persistent, being polite, being kind of helpful, but also trying to have that kind of positive sort of energy about these things and saying, look, we can use this as an example of how TIMS and our trusts can work together. We can get the communication right. We got them to kind of do summary letters to us at the end, which have been really helpful in terms of communication of what they've done with the patients that they've seen. And that was useful as a directorate to say, actually, this is an example of how the two organisations have worked together, and it can trickle down into other areas as well.
So what do you think the moment was, Ben, when you kind of think, this is working, it's going to happen? Was there sort of that tipping point or that moment where you thought, we've cracked this?
It was not. I mean, first of all, there was never a kind of a sort of a this is definitely not going to work. But it was just there was a frustration about trying hard to say this is what we want to do, and ultimately the organisation saying, well, we're doing that already, and you knew that they weren't, and trying to collect that information to say that everything wasn't as good as what it would do. The physios were struggling to book in follow-ups to see patients more than once when they had a new diagnosis, which is what we were trying to do. We tried to do audits and trying to get that organisation to kind of get the information together from their data that we wanted. But actually, they started to be able to tag each patient with AXPAR that came through to find out, these are numbers. They could start to give us numbers better than we could actually. They were a much more data-driven organisation than we could do in our trust. But it was really nice when we have our Monday morning spondyloarthritis MDT, which is, virtual. So it's very easy to say, well, actually, why don't you come along to that MDT just sign in at 8:30 on a Monday morning. And when that started happening, and their physio would come along, and we could identify for the first time a rheumatology team, which is what we've been trying to build within TIMS, and say, well, actually, we know which physios in your team are going to start seeing our patients, and we can have a two-way dialogue. And you can email me, and I can say, oh, great, you saw that patient, and I know them. It was that was sort of that kind of, you get that kind of warm feeling that this is working.
So do you therefore think that, well, I always think that this digital innovation post-COVID with our Teams and Zoom has actually really helped in the service?
Well, I guess also it's made having a working group across organisations easier. You have a monthly meeting, and it literally is an hour, at most, and it's in your diary, and you don't. It's easier for more people to join from different directions. Whereas I think the kind of attendance at those meetings would be much poorer if it had to be face to face. So yeah, and it's easier to kind of check in with people to kind of see that there's been some progress and that people are reasonably happy. So absolutely. I guess this is a problem that kind of emerged during COVID. But actually the solution has kind of also emerged during COVID. It hasn't been stuck.
Absolutely, because I think this Teams and Zoom and many teams has allowed what the title of this podcast is, collaborating across multiple disciplines, a lot easier. And then by seeing individuals, you build that relationship, and then I think it really ultimately helps in your goal, what you're trying to achieve. So, and as you said, both sides understand each other.
Yeah.
So, Ben, I suppose what I'm really keen to hear from you now is what would be your top tips to any of our listeners out there around if somebody was starting their own improvement project and they were thinking about how to go about engaging and involving their stakeholders within that process. What would you say your kind of top 3 tips, if you will?
Yeah, I think it is. You do need to actively sit down and think about who are the stakeholders. That's number one, isn't it? And what are their priorities? Why should they help here? And what kind of shared aims can you have with those stakeholders? So what are the things that will persuade them to help and to carry on helping? I think, as we've just talked about in terms of collaborating together, having kind of a regular working group and choosing who those people are, it's really been helpful for us to have almost a neutral person involved in that as well. So we had a quality improvement team that were involved in the trust. So there's been someone through that who's been helpful, almost in a sign of asking those questions that need to be asked, and trying to kind of be that person that isn't quite as set in their ways about what they want to happen. So that's been very helpful as well. So I guess they're not quite as brief and succinct as you might have, but it is understanding who the stakeholders are, what their priorities are, what the shared goals can be, and also trying to organise this kind of project in a way that works and potentially getting people from outside the kind of main camps to negotiate with you.
Ben, I'm really interested in this neutral person in the team. I think I sort of like the idea, but how do you think? Can you just elaborate a bit more on that, and how they were useful?
Yeah. So it's, I guess it's. I mean, there was someone who would kind of help to organise the meetings and say, and also to summarise what's agreed in the meeting, and would kind of, if things hadn't been moved on, they might push in that direction. And I guess from my point of view, I was, it's very clear what I want, and that if I push the other organisation, then, as I think Lucy said before, it's not very nice when someone is trying to tell you what to do. But this was someone who kind of was involved in the whole project, so understood what the aims of the project were, and I guess we're able to be neutral and not kind of pushing in a particular direction to get things done.
What's interesting, well, I haven't thought, I don't know whether you thought it, do you think having in these groups, these collaborating multidisciplinary groups, actually having a patient on there would actually would it be more powerful for us, as clinicians, in trying to encourage our stakeholders to engage more?
Yeah, it does, doesn't it? I mean, the meetings when you have patients there are amazing, and the powerful things that patients can say to persuade people to make changes to their practice far more effectively than what a consultant who just seems like they have their own, agenda. And you try and bring things back to patient care repeatedly, but it's still, you still have that risk of saying, well, you're doing this because this is your interest, and you're not thing. But that kind of, this is a real problem, this is a real impact, and yeah, absolutely, it's brilliant to have the patients involved in these.
And I mean, what I think is really interesting talking to you, you sound so enthusiastic. I mean, I'm really enthusiastic about your service and what changes you've done. Just for our listeners, I mean, are you able to just sort of give the top line results of your project that you embarked on?
Yeah, so I talked about sort of two parts of it, and one was in the first year, and that was about changing the referral pathways for people who've got suspected inflammatory back pain. And we wrote out a pathway which is now adhered to, and the community physios now use criteria to refer them. And I'm confident that they can choose patients to refer. So I guess in that way, we've also kind of spread that expertise about axial spondyloarthritis, which has been fantastic. So there's now a broader group of physios that now understand the condition. The second project is we haven't formally evaluated it now, but we now have an agreed pathway for what happens with patients who are newly diagnosed with axial spondyloarthritis that's actually across our trust, the neighbouring trust, the Gateshead Trust, and TIMS, who should all be saying, well, these patients should have up to 6 physio appointments. They should have their BASME recorded. They should be signposted to these sources of information, and they should have a tailored exercise program, et cetera, et cetera. So we've now got this agreed standard of care for patients who are newly diagnosed with axial spondyloarthritis.
It'd be very interesting when you audit that. I mean, you know what your outcomes are. But have you had an opportunity to look at that?
Well, that's what we're doing. So we try to audit what happened beforehand, and the data that we got. Part of the reason why we're now able to identify patients with AXPAR, and we're now kind of looking at how we evaluate this now that it's been implemented. So, in other words, how do you check? And this will be each physio who sees a patient newly diagnosed with AXPAR will complete the questionnaire that we're doing about what information has been passed on, how many times they've been seen, what's the change in BASME being across the programme.
Ben, as always, it has been an absolute delight to talk to you and to hear more about your project and your service. So thank you very much for joining us on today's Room for Improvement podcast.
Thank you, Lucy. Thank you, Hasan. It's been an absolute pleasure talking about it as well and listening to you too.
So learn more about the Newcastle team and their project by reading the NAS Aspiring to Excellence Learning Report, which is available on the NAS website. We really look forward to you guys joining us for the next episode. Thank you so much and goodbye.
This is a CPD accredited episode. To collect your certificate, please email aspiringtoexcellence@nas.co.uk and quote the code BEN. Room for Improvement is brought to you by the Aspiring to Excellence programme from NAS, which is sponsored by AbbVie, Biogen, Lilly, Novartis and UCB, and in partnership with BritSpa and the NHS Transformation Unit.